Hi, everyone. Welcome to our ICARE Genetics Case Conference for November. I'm Tua Pell. I wanted to get started on the first case, and then I will introduce our guest expert. So this is a case where the proband is a 40-year-old female with stage 3 triple positive left breast cancer, which was diagnosed a couple of years back, so at age 38. There was a TP53 likely pathogenic variant, splice acceptor. So the question here, I'm just going to go through the family history really quick. So we have here the patient. Her sister had testing, was negative. Sister's son, again, had testing. There was an RB, retinoblastoma diagnosis, again, was negative for the TP53 mutation. The mom had breast cancer diagnosed at age 34. This was back in 1993 when she passed away, so there was no testing done. The mom's sister had testing age 50. There's a diagnosis of breast cancer at age 51. Her results were negative, but the reason I bring attention here is there is some pancreatic cancer in the blue. So the mother's father had pancreatic cancer, and then 3 of his sisters had pancreatic cancer. So it's a strong history, but again, there's a lot of negative people in the family. So with that, consideration of pancreatic screening came up for this patient. So I wanted our guest expert to comment on it, but let me introduce you to our guest expert first, which is Dr. Bryson Katona, based at Penn Medicine, Perlman Center for Advanced Medicine. So Dr. Katona is assistant professor of medicine in the Division of Gastroenterology Hepatology at Penn. He's director of the GI Cancer Genetics Program. He's a physician scientist, did his initial training at UPenn, then his MD and PhD at WashU, and then postdoc back at UPenn. And he is also the current president of the Collaborative Group of the Americas Inherited Gastrointestinal Cancer, so better known as CGA. So I wanted to bring in Dr. Katona to comment on the case, and then he's got a great presentation lined up.
Great. Well, thank you so much for the invitation to come talk today about a topic that I deal with clinically daily and that I really enjoy talking about. So yeah, I'd love to talk about the case a little bit. I'm going to go back to the case real quickly here. Okay. Yeah. So I assume that this particular patient was going to be you all would be following her like she has LFS. I didn't have a chance to look at the variant specifically, but yeah. So in this case, we haven't totally defined what lineage the LFS is coming from, or whether or not it's de novo, but it seems to be coming from that maternal side, and I think in this case, I mean, I would personally err on the side of offering her screening. In LFS, we typically will start similar to a lot of the other genetic predisposition syndromes at age 50 or 10 years younger than the youngest pancreatic cancer. Now, there was a really young one over here, although you're getting a little bit far removed from the proband. I think with LFS, probably the more important considerations are that unfortunately, you can't really rely on the whole body MRI for screening because it's just not sensitive enough for the pancreas. And so if you were going to do screening on her, you would have to either do an endoscopic ultrasound, which could be paired with the colonoscopy and upper endoscopy she'll be getting every couple years, or have to do a dedicated MRI abdomen. But unfortunately, the whole body imaging just isn't sensitive enough. But I would definitely err on the side of offering it to her, although yeah, I think waiting till closer to 50 is probably reasonable.
Okay, thank you. That is what we did. We sent to Kira. So this is one of Kira's patients.
All right. So yeah, it's my pleasure today to talk about pancreatic cancer screening. I was told to try to keep this to about 15 minutes or so. This is normally a talk I give in about 45 minutes, so I will not waste any time, and I will get started here. Here are my disclosures. So today what we'll cover is really kind of do a rapid whirlwind tour through pancreatic cancer screening, talking about first risk of pancreatic cancer, then talk about who we should be sending for screening, how screening should be performed, and then review some of the recent data looking at screening outcomes. So as far as risk of pancreatic cancer, in the general population, the lifetime risk of pancreatic cancer is not that high. I usually typically quote patients for an average risk about a 1 to 1.5% lifetime risk of pancreatic cancer. Of course, we know that risk of pancreatic cancer pales in comparison to the proportion of cancer-related deaths that result from pancreatic cancer. Now, of pancreatic cancers, about 90% are thought to be due to sporadic, with about 10% due to either a known germline genetic susceptibility or a strong family history. And of those risks in these high-risk individuals, we know that risk is proportional to the number of individuals in the family that had pancreatic cancer. So the more individuals affected, the higher one's risk. There are also multiple different genes that can increase that risk, including the hereditary breast cancer genes, including BRCA1 and 2, ATM, and PALB2, the Lynch syndrome genes, exclusive of PMS2, where there has not been convincing evidence that there is increased pancreatic cancer risk. And then some of the rarer syndromes, such as CDKN2A, Leaf-Raumani syndrome due to a TP53 mutation, or Poit-Jaeger syndrome, and lastly, hereditary pancreatitis as well. So many different conditions out there that increase risk. But I really want to get to screening, which is the main area that I want to cover. And first, when we think about sending somebody for pancreatic cancer screening, in the ideal world, what should a pancreatic cancer screening test do? So this is getting kind of very fundamental and basic about the question, but with a pancreatic cancer screening test, we really want to be able to detect a cancer or a precancer at an earlier stage. We want to be able to do something because we found this cancer earlier. So in the setting of pancreatic cancer, we want to be able to take this patient for surgery. We ultimately want whatever we do to improve survival from the cancer. And of course, we don't want to create more harm than good. And in the ideal world, it would be cost effective, but that's a tough bar to get over. And because it's so difficult to get a good screening test that's effective, the U.S. Preventative Services Task Force has actually come out with very strong recommendations saying that in average risk asymptomatic adults, that pancreatic cancer screening should not be offered. However, of course, for high-risk groups, it's a different story, and there are lots of guidelines that are out there that will talk about who is eligible for screening. Unfortunately, all of these guidelines don't totally match up, so there are subtle differences between them. But I think some general principles that can be considered is that if somebody's pancreatic cancer risk over their lifetime approaches 5% or higher, typically that's kind of the threshold where we would definitely recommend screening. Of course, individuals have to be appropriately aged, and so we know that pancreatic cancer is not a cancer that typically affects younger individuals. The patient should be an acceptable surgical candidate, and so if you have a patient who could not undergo or withstand surgical resection for an early pancreatic cancer, you probably should not be screening them. And then ideally, patients before they embark on screening should have a thorough discussion of the limitations about screening, that there is cost associated with it. There are high rates of incidental findings, and although there is data supporting the benefits, this is an area where there's still a little bit of uncertainty. So thinking about the groups that are eligible for screening, we have the first three syndromes where family history is not required for eligibility. So that includes Poit-Jaeger syndrome, carriers of CDKN2A mutations, or individuals with hereditary pancreatitis. And for the hereditary pancreatitis, it is important that the individual have evidence of clinical pancreatitis. So you will find some carriers of these genes that have never had pancreatitis, and those individuals would not necessarily need to be screened. Now, there are also individuals that are screened based on family history alone. And so these are individuals with familial pancreatic cancer, which is when you have two relatives who have pancreatic cancer that are directly related to one another. And then your patient would be then directly related to one of these two individuals. And then finally, we have our hereditary genetic syndromes that do technically require a family history, including carriers of a BRCA1 or 2 ATM or PALB2 mutation, individuals with Li-Fraumeni syndrome, as well as Lynch syndrome. But typically for these individuals, they need to have a first or second degree relative with pancreatic cancer to really truly qualify. But I will ask, though, especially for these individuals with hereditary breast cancer risk, should we be considering screening in those individuals who do not have a family history of pancreatic cancer? And the reason that I bring this up is that we know that when you use family history as a criteria for deciding whether or not someone gets screening or not, there are certainly biases that can play into this. So sometimes patients have very small families, and so they may not have many individuals who would be at risk for pancreatic cancer. Sometimes people don't know their family history, or what history they do know is incorrect. And especially when we're talking about hereditary cancer risk syndromes, sometimes people, have died very early from other cancers. And so again, you just have less individuals who are at risk of developing, say, for example, pancreatic cancer. And I think what's also striking, and I think it surprises a lot of patients when we talk about this, is that the majority of pancreatic cancers in these gene mutation carriers actually occur in families where there's no family history of pancreatic cancer. And so we've been asking this question for a long time here at Penn about whether or not it's right to use family history as eligibility criteria for screening, BRCA1 and 2 carriers. So we actually started a study screening these individuals. We started this study almost 10 years ago now, where we've been offering individuals who are carrying a BRCA1 or 2, PALB2 or ATM mutation. We've been offering them pancreatic cancer screening in the absence of a family history of pancreatic cancer. And while I don't have time to go through the details, if you're interested, we published the initial interim results of this study a couple years ago in Cancer Prevention Research. But what we found was that we were having fairly similar rates of finding on these individuals compared to individuals that do have a family history of pancreatic cancer. And we also found that screening could be done very safely in these individuals. Unfortunately, the year after this paper was published, the American Society for Gastrointestinal Endoscopy came out with these new guidelines, which I think really shook the field. These were published about a year ago, where they recommended that all BRCA1 and 2 carriers, as well as all PALB2 carriers, undergo pancreatic cancer screening, really regardless of family history. So this has definitely helped from my perspective, from an insurance perspective, but I think a lot of places now are seeing more and more of these carriers without a family history who are coming in for screening. Now, if you're going to do pancreatic cancer screening, how should it be performed? So we'll talk about imaging, blood work, and then pancreatic cancer screening studies. As far as imaging, this is really the cornerstone of pancreatic cancer screening, and really should be done with only MRI with and without IV contrast or endoscopic ultrasound. We don't think that CT scan or transabdominal ultrasound are really sensitive enough to be used. And when comparing MRI and EUS, we know that MRI is the big pro is that it's non-invasive and it is better for detecting cysts, whereas EUS is much better for detecting solid lesions, which represent the vast majority of early pancreatic cancers. Certainly, there are cons to both of these procedures, but both of them have very high incidental finding rates, and so we're finding something on the pancreas in about a third of patients, and they're certainly expensive as well. But I tend to prefer, at least in my practice, I like to mix in EUS because I think in experienced hands, it really is a better test. And we've had multiple cases of early stage 1 pancreatic cancers that have been detected on EUS that have not been able to be seen on MRI. And so all of the patients that we follow here at Penn, either in most cases, they're either getting alternating EUS and MRI, or they're getting only EUS. Now, for blood work, there's been a lot of study of CA19-9 as a potential pancreatic cancer early detection test. However, at this point, I would say it's not an ideal test and should not be used alone for individuals who are at high risk. I think that if there is a multi-analyte blood test that's eventually brought to market down the road, CA19-9, will likely be a part of it. But I would not recommend checking CA19-9 on a regular basis on these high-risk individuals. There's been some really interesting data about diabetes and fasting blood sugar. What's been shown is that a subset of individuals who develop pancreatic cancer, up to 3 years prior to the time of diagnosis, you can see alterations in blood glucose levels and even development of diabetes. And so if somebody develops diabetes or has diabetes and it becomes much, much more difficult to control, kind of in midlife, there could be concern that a pancreatic cancer is developing. And so for my patients, I will typically recommend they get screened for diabetes on a yearly basis. And if they develop new diabetes, or if they had diabetes that has been constant for a while and it becomes much more difficult to control, I'll typically recommend Q6-month imaging for a couple years afterwards, just in the event that a new pancreatic cancer is developing. There's been a lot of work looking at other blood-based tests for pancreatic cancer early detection. Gallery test obviously is getting tons of press now. If you look at the data for how Gallery performs for pancreatic cancer, it has fairly low sensitivity for stage 1 and stage 2 pancreatic cancer, and so I don't think that this is a reasonable alternative for high-risk individuals. You may also have heard about the IMRE PanCan-D test. This was a test that was a blood test developed by a company called Immunovia. It was developed specifically for pancreatic cancer early detection. It had fairly good sensitivity and specificity in a validation study. It was on the market for a little over 18 months. However, the company actually pulled it off the market this summer as they're trying to retool their algorithm. So not currently available now, but may be back on the market, hopefully in the near future. So apart from monitoring diabetes, I don't think any of the other blood tests are really ready for prime time yet. I do think, though, that anybody getting pancreatic cancer screening, if possible, should be enrolled in a pancreatic cancer early detection study. Two that we participate in at Penn are the CAPS-5 study. This is a National Cancer Institute funded study. I think we're in our 8th or 9th year now, with locations primarily in the Northeast. There's also the newer consortium called the PROCEED Consortium. This is a rapidly growing consortium. I think it's up to like 40 centers now, with over 5,000 patients who are being followed, centers across the US and multiple institutions throughout the world. But it's really important for patients who are undergoing pancreatic cancer screening that we have the opportunity to collect data on them so that we can better refine our processes moving forward. And then finally, in the last couple minutes here, talk a little bit about some of the newer data looking at pancreatic cancer screening outcomes. So there have been several studies in this space, but I'll just highlight two of the more recent ones that I think are the most impactful. This is a study that was published earlier this year, coming from Netherlands. And for this particular study, they looked at CDKN2A carriers who were undergoing pancreatic cancer surveillance. They have a very large CDKN2A population that's followed in the Netherlands. And they matched these 1 to 5 to pancreatic cancers that were detected outside of surveillance. And if you compare those found outside of surveillance versus surveillance, what you can see is that in those outside of surveillance, about 3/4 were either stage 3 or stage 4. Whereas if you look at those in surveillance, only about 1/4 were stage 3 or stage 4. And so in this particular study, pancreatic surveillance did substantially downstage the pancreatic cancers in these individuals. Now also, they also looked at changes in overall survival. And they found that individuals who had surveillance-detected cancers had about a twofold increase in median survival compared to those detected outside of surveillance. Now, there was also late last year, there was data that was published from the CAPS-5 study, which is the NCI-funded study that we've been participating in at Penn. And I think this is very promising data, looking at about 1,500 high-risk individuals who are undergoing regular pancreatic cancer screening. In this particular study, what was found was that individuals who had pancreatic cancers detected during screening, the vast majority of these were stage 1 or stage 2, with only about a quarter of them being stage 3 or 4. And for those cancers detected outside of screening, almost all of those presented at stage 4. I think importantly, if you look at median survival and 5-year survival, for pancreatic cancers detected during screening, median survival was close to 10 years, and about 3/4 of patients survived 5 years. And you compare that to cancers detected outside of screening, where your median survival was only 1.5 years. And so, very, very dramatic differences between the groups. And so I think that, this data really shows that for high-risk individuals under careful surveillance, the screening can downstage pancreatic cancer and can improve long-term survival. However, it is important to note that even in these high-risk individuals, pancreatic cancer is not common. And so you do need to screen a lot of people to actually find high-risk lesions. There have been 2 meta-analyses that have been done recently, showing that you probably need to screen a little bit over 100 patients to find one high-risk lesion. And so cost effectiveness is a story for probably another day. So this is a kind of a whirlwind tour of pancreatic cancer screening, but I just want to leave you with a couple take-home points before we get to some more cases. And of course, happy to discuss any of this in more detail as well. But I do think pancreatic cancer screening should be considered if individuals are eligible. But I do think these individuals should have a discussion of the risks, benefits, and limitations before they embark on a pancreatic cancer screening program. If you do screening, I think you should do annual imaging of the pancreas, either with EUS or MRI. And I would argue that at least every other year, an individual should have an EUS if possible. And I think you should also follow blood glucose, or ideally hemoglobin A1C. Ideally, these individuals should all be enrolled in clinical studies, and certainly we need more research in this area. We need better screening strategies. We need biomarkers to allow for blood-based testing. We need to improve our imaging, and ideally incorporate AI into this imaging as well. And I think we need to do a better job of risk stratification because, as we do it now, I think screening a lot of people. I think we're over-screening a lot of people and probably, under-screening some as well. So we definitely need better risk stratification. So thank you again for the opportunity to talk today. I'd love to answer any questions about the presentation, or I know we have more cases to go through as well.
So thank you, Bryson. Excellent presentation.